He'll be talking to us on bone health in diabetes. Professor Chowdhury, please.
Thank you very much. It's always a pleasure to come back to this forum. And it's good to interact amongst different specialities. We talk about bone health. Do we have a time, right? Yeah. So bone health in diabetes. So what are the questions before us? First of all, we try to understand whether it's any different from those who do not have diabetes. If so, is it related to type 1, to the type of diabetes, type 1 or type 2? The overall concern, of course, is whether this individual gets a fracture. So if someone with diabetes gets a fracture, are the results any different from someone who doesn't have diabetes? And then if we actually find that there is a difference in the bone health, then do we understand why it is so? Whether there could be an effect of the anti-diabetic medications that we use, and then how do we assess bone health in diabetes? Is it any different? And finally, how do we manage? So I'll try and cover as much as possible of that. So there would be a lot of data, but I have put up this one, which looks at 6.5 million people, population-based cohort study, and with a follow-up of 6.5 to 7 years, which includes healthy population, type 1 diabetes, type 2 diabetes. And there was a higher fracture risk in diabetes by about 32% here. And there is a difference between type 1 and type 2. The risks of fracture are higher in type 1 than in type 2 at all the sites examined, but more so at the hip. So these are the clear starting points. Yes, diabetes is associated with increased risk of fracture. The risk is more in type 1 compared to type 2. And the risk is greatest at the hip. The increased risk is most at the hip. And there is also an interesting observation, a population-based study from Canada. Fairly large number of individuals were compared, healthy population versus diabetes, and it's in type 2 diabetes here. It suggests that new onset diabetes is associated with lower risk of fractures. Only long duration diabetes is associated with higher risk of fracture. So clearly maybe something that we as diabetologists are doing may be actually making their bones worse. I don't know. Let's see. So what are the risk factors for fractures in someone with diabetes? Well, type 1 diabetes heads the list. In type 2 diabetes, longer duration of diabetes, poorer control of glucose, and also presence of complications, microvascular complications. And finally, something about treatment. Those treated with thiazolidinediones, we have only pioglitazone with us at this point of time, treated with sulfonylurea, and treated with insulin. These are the ones who have higher risk of fractures amongst those with diabetes. And this is a slide that shows quite elegantly that lower A1C versus higher A1C, the fracture risk is significantly higher in those who have poorly controlled glycemia. What about fracture outcomes? Once you have a fracture in someone with diabetes, the outcomes are also poorer. And it's partly because of wound healing is affected in diabetes, infections probably are more frequent, cardiovascular outcomes are worse in diabetes compared to non-diabetes. So overall, hospital stays longer, and eventual results long-term are also worse, and mortality rates are higher in diabetes who sustain a fracture. So all in all, diabetes is associated with poor outcomes following a fracture. Now, this is something very important. I'm sorry that I couldn't be there throughout the morning program because of commitment in elsewhere. But we need to remember that fracture risk derives from bone strength, and bone strength is determined by two important entities: bone quantity and bone quality. However, it does appear that 70% of the variability in bone strength is determined by bone quantity, which we can assess with the help of bone densitometry study. So bone quantity is very important, and that's why osteoporosis or fracture risks are assessed internationally anywhere with the help of DEXA BMD measurement. And if we look at bone density, type 1 diabetes definitely has lower bone density. The diamond is on the left of the zero line, suggesting that the bone density is worse. What happens in type 2 diabetes? Well, this is the pink one is for women, the red one is for men, and the blue one is overall. So overall, the bone density tends to be on the right side, means bone density is higher in type 2 diabetes compared to non-diabetic individuals. But we also committed ourselves to a statement that fracture risk is higher. So bone density is high, but fracture risk is higher. And how much high is it? About 5 to 10% higher than the normal population, healthy population. So then BMD is lower in type 1 than in type 2, but fracture risk is increased in both, albeit to a lesser extent in type 2 than in type 1. And this is now understood to be because of poorer bone quality, bone microarchitecture being abnormal, while trabecular bone is also importantly involved. It is supposed that possibly there is also important changes in the cortex of the bone, which may be thicker, but there may be more pores in the cortex also. Beyond that, type 2 diabetes is associated with aging population, with other comorbidities. So frequency of falls is more, so the fracture risk is more. And then we could have additional confounding with different medicines that are used to treat type 2 diabetes, or even the other conditions, which can again lead to falls. Antihypertensives could lead to a postural fall in BP and hence a fall. Now, this is a busy slide. I'm sure no one except me can read what's over there, but I'll just quickly summarize what it suggests. It tries to make us understand why we can have weak bones in diabetes. So at the bottom is insulin deficiency as we see in type 1 diabetes. We can see that in long-standing type 2 diabetes also. That is a state of insulin deficiency, which can affect osteoblast function as well as osteoblast proliferation. Apart from that, we have other issues like adipose tissue, which can act through adiponectin, leptin, other factors. Then there is incretin effect. Then there is effect of hyperglycemia itself. We have the adiposity we have talked about, and then together they also lead to more reactive oxygen species, more inflammation. All of these can adversely affect bone health. We don't have the time to go into all the details of that. Now, we do need to understand that in type 2 diabetes, therefore, there is an increased risk of fracture, but the bone density is not low. So bone density measurement will underestimate the fracture risk in type 2 diabetes. However, even in type 2 diabetes, so if you are comparing between normal healthy individuals and type 2 diabetes, your bone density will not tell you what is the percentage increase in the risk of fractures. But within type 2 diabetes, bone density will still stratify the fracture risk. So if you have within type 2 diabetes those who have lower bone density compared to those who have higher bone density, overall, the lower bone density people will have higher risk of fractures. We also need to remember that vertebral fracture generally we think is not likely to give rise to a lot of morbidity or mortality compared to hip fractures. Hip fractures directly leads to more disability, more complications in the short term and also in the long term. But individuals with both type 2 diabetes and vertebral fracture had been found to have increased mortality compared to those without either or with any one of the two, just with vertebral fractures or just with type 2 diabetes. So if you have type 2 and vertebral fracture, that itself suggests higher mortality in the long run. Now we come to diagnostic assessment. So what should we do in type 2 diabetes? Whom should we assess for their bone health especially? Well, as in non-diabetic individuals as well, general recommendation would be to assess for anyone who is 65 and above. Even at a lower age in those with diabetes, we would like to assess in some way or provide more attention to individuals who have longer duration of diabetes, higher A1C levels, more microvascular complications, frequent falls, use of glucocorticoid, of course, is not directly related to diabetes, and also, again, it comes up, use of medications like pioglitazone, sulfonylurea, or insulin. We talked about bone quantity, which we commonly measure with the help of DEXA, bone densitometry. What about bone quality? We did say that bone density doesn't tell us all, so we should assess bone quality. Well, this is more difficult to assess. One of the ways is a trabecular bone score, TBS, which can be done on previously done DEXA BMD. If you have the software is costly, as Professor Rathindranath Mukherjee will vouchsafe for me that when we tried to get that software, did we finally get it after I left? Yeah. So it was a costly proposition. We had a bone densitometer with us for quite some time, but we were unable to get the government to give us the extra software to measure this trabecular bones score. So TBS is possibly one of the easiest. Then you can have hip structural analysis from CT scan. You can have a peripheral, high resolution peripheral quantitative CT, HRPQ-CT, or you can do bone histomorphometry. Clearly, this is not what most clinicians will have access to. Even very specialized research institutes will have access to. So trabecular bone score, what does it do? This, on the top is sort of healthy trabecular bone in the vertebra, and at the lower panel we see altered trabecular bone, affected trabecular bone. So this is done using a special software based on pixel gray variability, and this is done on spine DEXA. What are the reference ranges? Again, we do not have a WHO defined reference range. Roughly, we take it maybe above 1.3 or 1.35 is to be normal. 1.2 to 1.35 is in between, and less than 1.2 is bad. And it's applicable only to the lumbar spine so far. Here we do see that in diabetes-related fracture risk, you see the odds ratios, which would tell us the risk of fractures in relation to lumbar spine bone density, femur neck bone density, total hip bone density. Whereas if you use lumbar spine trabecular bone score, you have significantly increased risk related to diabetes, whereas the bone density measurements do not give us this information. And how is TBS in people with diabetes? Diabetes is associated with altered and actually reduced trabecular bone score. We will not have the time, or neither are we inclined to go into the details of the other methods of assessing bone quality, but overall, I can show you in sort of a pictorial representation how bone picture would differ from healthy to type 1 diabetes, where everything is thinned out, to type 2 diabetes. It's not so thinned out, but the cortex appears thicker, but a little bit porous, and the trabecular architecture is a little bit affected. And then if we could do a bone histomorphometry, typically type 2 diabetes is associated with less uptake of the label. So here is good uptake of the label in healthy bone and very little uptake, no uptake here in a person with diabetes. And this suggests that type 2 diabetes, the bone affection, possibly is more of a low bone turnover state. Beyond bone quality and bone quantity, which indirectly tell us about bone strength, we have further advancement, finite element analysis, micro indentation techniques, which again is not at all available to us, but could be elegant ways to directly assess bone strength. This is what we actually want to measure. We were trying to predict the bone strength from bone quantity first and then maybe bone quality, but directly it will be better to measure bone strength. So now how do we assess? So we did understand the limitations of DEXA BMD in type 2 diabetes in assessing fracture risk. Then of course, even without DEXA BMD, we do not have DEXAs all across the country. So the FRAX is a good tool. We understand where, with the help of a number of questions, relatively simple, straightforward questions, you could predict the next 10 years' risk of major osteoporotic fractures or hip fractures in individuals, diabetes or otherwise. However, in this rheumatoid arthritis, paying respect to the rheumatologist, has been included as one of the factors that affects bone health, but diabetes doesn't appear there. So people have tried to see whether we could tweak this FRAX score in some way so that it gives us a better representation of the bone health in diabetes. So one way could be increase the age input by 10 years. So instead of 60, you write 70 over there, so the risk will be increased. Or you tick the rheumatoid arthritis box, cheat your way through. The person doesn't have rheumatoid, has diabetes, but you tick the rheumatoid arthritis box. Or you reduce, wherever you're using it separately, the T-score. Instead of minus 2.5 being your diagnosis of osteoporosis, you use minus 2 as your diagnosis of osteoporosis in type 2 diabetes. And then the other could be to use a trabecular bone score adjustment to FRAX. And this is incorporated in a more sort of sophisticated version, the FRAX Plus, which includes trabecular bone score and various other factors as well. So what about so coming to the later part of the talk in terms of treatment, what do the various anti-diabetic drugs do to bone? So if you look at our traditional sort of basic treatment for type 2 diabetes, metformin, it is, if anything, reduces maybe fracture risk, or it does not affect adversely at all. So metformin does not adversely affect bone health in diabetes. Sulfonylureas possibly increase the risk of fractures. That's a possibility. Not directly on bone density, but maybe through other ways, one of which could be by increasing the risk of hypoglycemia. Hypoglycemia increases the risk of falls, and therefore you fracture more. Glitazones, pioglitazone, definitely increases fracture risk, and that there is also evidence that it decreases bone density. GLP-1 analogs, again, neutral. DPP-4 inhibitors, by and large, neutral, but there have been some studies in the past which have suggested that they have a favorable effect on bone health. SGLT2 inhibitors, largely today considered to be neutral on its effect on bone, though there's been one of the studies using canagliflozin suggested that it increased the risk of fractures. And insulin, surprisingly, is associated with increased risk of fractures. Again, here, it may not be a direct effect of insulin on bone. It could be that the ones that you are using insulin in are the ones who have got all the other complications or an advanced stage, and therefore their bone health was already compromised. So it may not be a direct effect of insulin, but this is what the study suggests. So do we understand the mechanism of increased fracture risk with the use of thiazolidinedione like pioglitazone? Possibly, yes, we do. There are different mechanisms, one of which is easiest for me to understand is that these medicines cause differentiation of mesenchymal stem cells, and they could either differentiate into osteoblasts or it could differentiate into adipocytes. So glitazones, they cause differentiation in the adipocyte pathway, so thereby depriving the osteoblast lineage. And there are various other mechanisms whereby it can affect bone health. So what has been observed generally, again, there will be individual studies which may suggest differently, is that in women especially, large numbers of studies would suggest that the bone health compromise, the fracture risk increase is especially seen in women, especially postmenopausal women, not so much in men. So in postmenopausal women, use of pioglitazone possibly is not a good idea. So what do we do? How do we treat? Final 1 minute, 1.5 minutes. So of course, maintain vitamin D, ensure adequate calcium intake, as much as of that possible from natural sources through diet, if necessary supplements, and exercise. Exercise, not only aerobic exercise, but also muscle strengthening exercise. What about treatment for osteoporosis? The bisphosphonates generally stand out to be good. The effects are as good as in non-diabetic individuals. With the newer agent denosumab, the costlier agent, but very effective agent, somehow the study did suggest, at least in the first 3 years of use, the diabetes subgroup had an increased risk of fractures. However, when this was continued up to 10 years, this increased risk was no longer seen. So, nonetheless, if we are going to, so the other, we'll come back to the choice of drugs, or did we miss somewhere? So, by and large, I think bisphosphonates would still be the first line drug for use in osteoporosis in type 2 diabetes. Though to me it sounds a little bit not, time is up? No. So, it doesn't quite sound right, because I did mention that it is a low bone turnover state, where we should actually be using more of bone-forming agents. Now, teriparatide, the studies have not clearly shown a great deal of difference. Neither do we have a whole good lot of studies in diabetes. But denosumab possibly will come later than bisphosphonate. And then we also need to develop proper exercise programs for sarcopenia, which is a major problem not only for osteoporosis but also for type 2 diabetes. So exercise, resistance exercise training beyond aerobic exercise is also important. So with that, I would like to conclude to suggest that type 2 diabetes and osteoporosis may not be osteoporosis, but poorer bone health are linked. We need to actively look for bone health and treat for poorer bone health in type 2 diabetes. In terms of diabetes management, sulfonylureas, metformins and DPP4 inhibitors would be better choices, even GLP-1 receptor analogs. TZDs would be a major red mark. SGLT2 inhibitors, plus minus. Insulin use, this particular algorithm does suggest avoid. I would not go on to say that you have to avoid, but hypoglycemia avoidance is something that's important, and check for the various other complications. So in terms of treatment, bisphosphonates are given first choice. Thank you very much.
Thank you, Professor Chowdhury. Now anybody can ask 1 or 2 questions from the floor. We can allow 1 minute. Any questions from the floor?
Food was excellent. The lunch was excellent.
It was excellent.
Yeah.
Your deliberation was excellent, and if there is no questions, I just out of my curiosity, I just want to ask you, though this does not directly fall into my domain, still then, as an internist, I do feel that I should know. I have learnt a lot. But then, in case of SGLT2, which is now used rampantly, of course, everyone, because of his lot of protections, not only diabetic, kidney, heart, everywhere. Now, the thing is, probably the mechanism, do you think that's relative to some amount of retention of phosphate, which can cause the turnover of bone, from the relative hypocalcemia, and leading to all these things? Any hypothesis like that?
Yes, hypothesis is there, and you're perfectly right, as you are so well read, Mrinai. High phosphate causes stimulation of parathormone secretion, and that parathormone possibly weakens the bone. That's the working hypothesis. However, it was seen with only one part of one study with canagliflozin, not seen with others. So we still do not know whether actually it's a major concern.
Shravanta, one question. Vitamin D deficiency being so endemic in our country, how do you see it playing out in the diabetic population and confounding the bone density results, or also affecting your treatment choices?
Well, if we look at vitamin D deficiency in diabetes versus non-diabetes, because in the non-diabetes also it's so high, the difference becomes very little. So especially we would, of course, like to have better vitamin D levels, and I think from the point of view of bone health, values of 20 nanogram per milliliter and above are reasonably okay. we would like to have even higher levels, 30, 40, maybe for various other pleiotropic benefits for which we do not have firm evidence that they actually better. So at least above 20, we feel mentally more comfortable if it's above 30. So it would happen, widespread rampant vitamin D deficiency will impair our interpretation of the DEXA BMDs in diabetes as well as in non-diabetes.
Thank you, Subhankar.
Thank you.
Deliberation. And the session is closed.